Assalamu alaikum, everyone. Welcome to the Uro-Oncology session at the Shaukat Khanum Cancer Symposium. Just a few house rules to begin with. We will take questions from the audience at the end of the session. We'll run through the talks in the beginning. We'll start off with Professor Rob Jones, who is a clinical Professor of Clinical Cancer Research at the University of Glasgow and Beatson Oncology Centre, specializing in prostate and bladder cancer. Research interests focus on clinical trials and new drug development. He's been involved in the development of many of the drugs used to treat urological cancers today and maybe tomorrow as well. And we'll kick off with his talk of updates in prostate cancer.
Hello, my name's Rob Jones. I'm a genitourinary medical oncologist from Glasgow in the UK, and it's a great pleasure to be speaking to colleagues across the world today, and thank you to the organisers for inviting me. So the title of my talk is Advanced Prostate Cancer, What's New and What's Next? I'm going to talk exclusively about metastatic prostate cancer today. These are my declarations of interest. So this is just a rough list of the licensed drugs in advanced prostate cancer today. And I guess what you can see here is the pace of progress, particularly over the last decade or so. And this has created massive opportunity, but of course it's also creating some difficulties. So it's about how we arrange the deck chairs to get the best possible outcomes for our patients. So I'm going to summarize today's talk really in two lessons. The first lesson is that the first treatment is the most important. We've known that in other cancers for a long time, but it's taken us quite a long time to come to that realization in prostate cancer. And this is probably the best example of that lesson. These are data from the Stampede trial on the left and from the Q301 trial on the right. So the Q301 trial was the pivotal trial of abiraterone, and that was in patients who had failed docetaxel with castration, metastatic castration-resistant prostate cancer. And what you can see there is that abiraterone in that context adds around about 4.5 months to overall survival on average. Conversely, on the left, the same drug simply given earlier at the point of hormone-sensitive metastatic prostate cancer, the same treatment is adding nearly 3 years to median overall survival. And so just shifting the treatment earlier appears to be a singularly important thing that we can do for our patients. And of course, this has been proven true with docetaxel and most of the other androgen receptor pathway inhibitors. The second lesson is that the androgen receptor remains the most important target in prostate cancer, although I am going to tell you about some others. Just a brief comment on terminology here. There have been a number of generic terms, collective terms for abiraterone, enzalutamide, apalutamide, darolutamide, but I'm going to refer to them as androgen receptor pathway inhibitors, or ARPs, and that's the preferred term from the Lugano International Consensus Conference last year. I think there are two fairly broad statements we can make about the ARP drugs. First is it probably doesn't really matter which one you get. And the second is if you've already failed on one, the chances of another working are minimal. And I think we've got lots of evidence to support that now. So what's next in metastatic hormone-sensitive prostate cancer? Well, first of all, PARP inhibitors. These are not new in prostate cancer. A brief history of PARP inhibitors. PARP inhibitors inhibit PARP, which is responsible for single-strand DNA repair, and thereby you get a build-up of single-strand breaks, which at the next cell division turn into a build-up in double-strand breaks, which will be repaired by the homologous recombination repair genes, principally BRCA. And so PARP inhibitors are specifically and selectively active in patients with mutations in one of these homologous recombination repair genes, particularly BRCA, because in those patients, the double-strand breaks cannot be repaired, and so the cell dies. And so we've known this for some time. This was the TOPE-HARP trial, which was the first phase 2 trial that we did in prostate cancer with olaparib. And we took 49 patients with freshly biopsied and freshly sequenced tissue. And what you can see is on the left there are the patients who responded to treatment, and all but one of those patients had a defect in one or other of the homologous recombination response genes. Conversely, on the right, you can see that all but 5 of the patients who did not have a mutation did not respond to the treatment. So this strongly advocated that PARP inhibitors would be selectively active in patients with HRR mutations. And of course, this led ultimately to the PROfound trial, randomized phase 3 trial. These are just the patients with BRCA mutations, and you can see that this led to both clinically and statistically significant survival advantage for patients with BRCA mutations. And then more recently, we've seen the data from the TALAPRO-2 trial and also the PROPEL trial, which is bringing this into the frontline setting in metastatic castration-resistant prostate cancer, combining with either enzalutamide, talazoparib with enzalutamide, or olaparib with abiraterone, respectively. I'm going to tell you about the TALAPRO-2 trial because this is the trial that I was involved in. This is the trial which has got some interesting new updated data. This was a quite slightly complicated trial because it took all comers, not just patients with mutations. Patients were randomized to receive either enzalutamide and placebo or enzalutamide and talazoparib. And there were these 2 cohorts of patients. The first cohort patient who was the whole group, patients who were unselected, and the second was an enriched cohort, which included only patients with detectable HRR mutations. The primary endpoint was radiographic progression-free survival, and this is the updated data on the right, and you can see that this is for the whole group, that cohort 1, so this is unselected patients. You can see there's a significant improvement in radiographic progression-free survival, about 14 months improvement at the median. But most importantly, we now have the survival data. So these are the patients with BRCA mutations. Not surprisingly, we're seeing quite a big benefit in favor of the combination. The hazard ratio there, 0.5, a 50% reduction in the risk of death. If we look at the HRR cohort, this is patients including BRCA, but all those other HR mutations as well. You can see that, again, there's still a significant survival signal. Hazard ratio has gone up a little bit to 0.62. And finally, if you look at the whole group of patients, so this is all patients, irrespective of whether they have an HRR mutation, we're seeing a significant survival advantage here too, with a hazard ratio of 0.8. Now, the question is that survival signal in the whole group being driven by the subgroup of patients who have BRCA mutations or the subgroup of patients who have other HRR mutations? And to my mind, it's these recent data which are most provocative. Because on the left here, we have patients where the patient did not have a BRCA mutation. Now, these patients were all doubly tested for circulating tumor DNA mutations and also for solid tumor DNA mutations. These are only patients who had absent BRCA mutation on both tests. And you can see that these patients had a survival advantage with a hazard ratio of 0.75. And if you exclude all HRR patients on the right, so again, this is patients who had a negative test for all HRR mutations, both in the liquid blood test and in the solid tumor test, we're still seeing a strong trend towards a survival advantage with a hazard ratio of 0.78. And so to my mind, these are the strongest data we've seen yet that PARP inhibitors have a clinically meaningful impact even in patients who do not have sensitizing mutations. And of course, the next question is, well, what about if we bring PARP inhibitors forward in combination now into the hormone-sensitive setting, which of course is where we're all now using these ARPI drugs. And we've just recently seen the first results from the first of 3 large randomized trials exploring this concept. So this is the Amplitude trial. The PARP inhibitor is niraparib, the ARPI is abiraterone, and this is a trial is conducted purely in patients with HRR mutations. And the primary endpoint is radiographic progression-free survival. And we've seen these are the rPFS data. On the left in the BRCA population, where you're seeing a significant reduction in the risk of progression, again, hazard ratio 0.5. And on the right, for the whole HRR mutation population, again, seeing a significant rPFS advantage. The hazard ratio 0.63. Now, of course, to my mind, it's really important that we demonstrate that we really are that we're actually bringing about overall survival gain here. And of course, these data are still quite immature from a survival perspective. And I think it's fair to say that to date, whilst there does seem to be a trend in both groups towards a survival advantage, it's not. It's far from proven. And I think we do need to see a stronger survival signal than this before we conclude that we should be bringing PARP inhibitors forwards into the hormone-sensitive population. There's TALAPRO-3, which is a very similar design trial with talazoparib and enzalutamide. And there's also a trial of a novel PARP inhibitor called saruparib, and that trial is actually including a cohort of patients who do not have HRR mutations. What about radioligand therapies? This is PSMA lutetium. We've seen data from the Vision trial for some time ago now. So this was patients who were taxane and ARPI exposed, previously taxane and ARPI exposed with metastatic castration-resistant prostate cancer, and they were randomized to essentially best supportive care or best supportive care and PSMA lutetium. And we saw the primary analysis of this showed a significant overall survival advantage, median survival gain of about 4 months, but this is right at the very end of life, really, in men with advanced prostate cancer. We've also seen the results of the PSMA-4 study, which again is a similar design, but in this case, this was in patients who had only failed an ARPI drug, and they were randomized between lutetium and an alternative ARPI drug. And the primary endpoint was radiographic progression-free survival. The trial was positive, but of course, the slightly unexpected, in my view, finding from this was that the overall survival signal from this trial was really absent. Now, there are reasons for this. Patients were crossed over, and so it may be that this is simply because patients in both arms ended up getting the PSMA lutetium. But I think we can conclude that giving early lutetium, at least in the castration-resistant setting, may not give an overall survival advantage compared with giving it later in the pathway. And that, to my mind, was a little surprising. But I guess the reason I'm talking about this is because we've just seen this press release from Novartis that their study PS-MADITION, which is randomizing patients with hormone-sensitive prostate cancer who've just started doublet ARPI ADT therapy for and against lutetium. And all we know is that this trial is positive for radiographic progression-free survival. I think we're going to see the results of this trial at a meeting soon, possibly the ESMO meeting. So this is an exciting development for lutetium because it may bring this forward into the hormone-sensitive population. But of course, we now have a bit of a problem here, don't we? Because we don't really know how to treat every patient that comes through the door with metastatic hormone-sensitive prostate cancer. We acknowledge that the first treatment is the most important. And I think it is, by today's evidence, it is a given that all of these patients should be getting a doublet androgen deprivation therapy plus one or other of the ARPI drugs. And as I said at the beginning, it looks like it doesn't much matter which one. But we've now got growing evidence for triplet therapy. We've seen data with adding docetaxel with a couple of years ago. Again, quite persuasive evidence. We've seen now, or we're going to see evidence that lutetium is effective, and we've also, and I've not had time to tell you about this, but we've also heard that there's a positive trial in this setting for a drug called capivasertib, which is an AKT inhibitor. And we've already seen data for PARP inhibitors, and we will see more. And so actually, whilst all patients should be getting a doublet therapy, should they all be getting a triplet therapy? And if so, how do we choose which one to give? And the reason I raise this is because there are some interesting data which have recently been published in Cell by the Stampede group, of which I'm a part. And this is attempting to find if we can select patients with metastatic hormone-sensitive prostate cancer who are going to benefit from docetaxel in this case. So this is using the Decipher test, which is an mRNA expression profile test, which has been in use for some time as a prognosticator in early disease. But what you can see is patients with a low Decipher score do not appear to get any benefit from adding in chemotherapy. Conversely, this test does not distinguish which patients benefit from abiraterone in Stampede. And so this might be a test which would enable us to choose patients who are going to benefit from triplet therapy with docetaxel. That's still to be proven. But conversely, it might also help us choose patients who are Decipher low who may benefit from one of the other triplet therapies. So, what about the androgen receptor? So I said at the start that the androgen receptor remains the most important target, and of course that's where this doublet therapy ADT-RP story has its foundation. But there are some new things coming out with the androgen receptor as well. The first is this is estrogen. Estrogen is not a new thing. In fact, estrogen has been used for many decades as a treatment for prostate cancer, and one of the first pharmacological castrating therapies, in fact. But of course, and it works by providing negative feedback on the anterior pituitary, so it switches off LH production, and that switches off testicular testosterone production. And we've known for a long time that oral estrogens are highly effective as castrating drugs. But of course, we've also known for a long time that they are quite toxic when given orally, because you have to give quite high doses and you get prothrombotic effects. But the latest trial I'm going to show you is actually using transcutaneous estrogen. So these are essentially hormone replacement therapy patches where, because of the avoidance of first-pass metabolism by the liver, you can get away with microgram doses of estrogen, which we already know do not cause those prothrombotic effects. And so this is the UK patch trial, which is part of the Stampede trial, but also part of another trial. It's got two cohorts. It's got a high-risk locally advanced cohort and a metastatic cohort. We don't actually yet have the results of the metastatic cohort. But what I'm going to show you is the results of this high-risk locally advanced cohort. Now, of course, this is a randomization comparing conventional LHRH agonist therapy with transcutaneous estrogen. So two alternative castrating agents. We do not expect it to be more effective. We expect it to have the same efficacy as a castrating agent. And indeed, that is what we do show. This is a non-inferiority trial, large number of patients, look, and you can see that there's clear non-inferiority, and there really is no difference between and there's certainly no statistically significant difference between the two arms of this trial. And so transcutaneous estrogen may become an alternative to LHRH agonist injections. It's a very cheap and easily available treatment, but it also has some other advantages because it has a different toxicity profile. In particular, I'd highlight that hot flushes are much less frequent with estrogens than they are with the LHRH agonists, although conversely, gynecomastia is more common with the transcutaneous estrogen than with the injections. We also see that bone mineral density is actually improved with patients on estrogen. It's not surprising, but we also know that is increasingly a problem as with LHRH agonists, particularly as we intensify treatment with the ARPI drugs. So it may be that transcutaneous estrogens, although not providing a survival gain, may actually provide a cheap and effective alternative to patients who are struggling or patients in whom LHRH agonists may be contraindicated. And then finally, I'm going to tell you a little bit about targeting androgen receptor mutations. We know that when patients become resistant to drugs like abiraterone and enzalutamide, one of the resistance mechanisms is the acquisition of mutations in the ligand binding domain. And what happens when you get a mutation in the ligand binding domain of the androgen receptor is that the androgen receptor will then bind to other steroid hormones. We don't necessarily know which ones, but essentially the receptor has become what we call promiscuous. That is, it will now, instead of binding and being stimulated by testosterone, it will bind and be stimulated by other steroid hormones in the circulation. And opevesostat is a fairly simple drug in its mechanism of action. It inhibits CYP11A1. Now, CYP11A1 is right at the top of the steroid hormone biosynthetic pathway. So it inhibits all adrenocortical steroid hormone production, and it's a very potent drug. So it effectively renders the patient Addisonian by switching off all of those steroid hormones. Now, of course, that's a problem because we do need some steroid hormones, but of course we actually know how to manage that. We simply give patients steroid hormone replacement therapy with a glucocorticoid and a mineralocorticoid, and you can maintain patients' adrenal function in that way. So the drug works by switching off the promiscuous ligands for the patients with the ligand binding domain mutation. And these are the results of a phase 1/2 study that we've been conducting with this drug. And this is patients who are castration resistant. And on the left, we have patients with detectable ligand binding domain mutations. And you can see the PSA responses there in the waterfall plot. Interestingly, we also included a cohort of patients who did not have detectable androgen receptor ligand binding domains. And you can see, although the response rate is lower, we are still seeing a significant proportion of patients with at least a PSA response. And this drug is now is now the subject of 2 large randomized phase 3 trials. And those trials are incorporating both patients with and without ligand domain mutations. So this may be the first androgen receptor targeted therapy which will be effective in patients who are not just castration resistant, but they are ARPI resistant. So to summarize my key messages, the first message is that the first treatment we give is the most important. We are rapidly moving from ARPI doublet therapy now to triplet therapy, but we urgently need to know how to select which additional drug to give in that triplet, because we're seeing a rapidly emerging plethora of new data regarding new drugs. And secondly, the androgen receptor targeted therapies have been the greatest giver, and they've been the greatest giver in the last century and also in this century, particularly with that doublet intensification in hormone-sensitive prostate cancer. But that story is not yet over, because the androgen receptor is still a viable drug target, even in the context of the more potent drugs we've been using over the last decade. Thank you very much for your attention.
Thank you very much, Professor Jones, for such an interesting talk. If you could be kind enough to stay with us till the end of the session, and hopefully we'll take questions regarding all the talks at the end. Thank you.
So the next speaker is Dr. Mohammad Habibullah Khan, who is consultant oncologist and medical director of quality and disease site-specific groups at the Ellen Blair Cancer Center. Dr. Khan brings over 2 decades of international experience in oncology with subspecialty expertise in breast, genitourinary, head and neck, and melanoma cancers. He has led and contributed to major clinical trials published in peer-reviewed journals and remains deeply committed to advancing multidisciplinary evidence-based cancer care here. Please welcome Dr. Habibullah Khan.
Today, I will be speaking on a subject that sits at the intersection of innovation and clinical need: renal radiation. With particular emphasis on stereotactic ablative body radiotherapy or SABR. I don't have any disclosure for this presentation. Historically, radiotherapy for renal cancer was plagued by toxicity, with the small bowel often bearing the brunt, leading to significant GI toxicities. But the emergence of stereotactic body radiotherapy has transformed the landscape, delivering precise cell death. Earlier trials in 80s and 90s showed no survival gain with conventional postoperative radiotherapy, only reduced regional failures at a cost of high morbidity. In this presentation aims to provide the insight beginning with foundational knowledge before transitioning to practical applications. SBRT is an effective and safe option for patients with inoperable localized renal cancer, and it has a role in oligometastatic or oligoprogressive disease settings. Novel clinical trials exploring stereotactic radiotherapy with systemic therapy hold promising potential for patients with renal cancer. SABR succeeds in renal cell cancer because it works differently than conventional radiotherapy. Traditional radiation relies on DNA damage and mitotic death, ineffective in RCC, slow-growing, radioresistant biology. SABR instead delivers ablative doses that collapses tumor vasculature through endothelial apoptosis, activating ceramide sphingomyelinase pathway to release antigens and trigger cytokine-driven immune responses. In doing so, SABR not only destroys the tumor but reshapes its microenvironment, explaining why it pairs so powerfully with immunotherapy. Although surgery remains the cornerstone for localized renal cancer, partial nephrectomy is preferred, preserving kidney function while removing the tumor. When that's not feasible, radical nephrectomy, often laparoscopic or robotic, is performed. But many patients with an average diagnosis of 65 face comorbidities that make surgery risky or impossible. This leaves a therapeutic gap between patients needing curative therapy but unfit for operating room. SABR walks into this space and has emerged as a safe, effective, and truly non-invasive alternative. For patients unfit for surgery, other options included thermal ablation, which has become the standard alternative, radiofrequency cryoablation, microwave techniques, which can achieve 90% local control, especially for tumors under 3 cm away from the renal hilum. But outcomes are limited by anatomy, size. Larger or complex tumors carry higher failure risk, and lesions near the collecting system may be unsafe. While complication occurs in fewer than 10% of cases, including bleeding, post-ablation syndrome, these constraints still restrict widespread use. This is where the SABR radiotherapy or stereotactic body radiotherapy transformed the treatment landscape for localized renal cancer. Unlike thermal ablation, which is limited to small peripheral tumors, SABR can safely target larger or centrally located lesions. Once considered untreatable without surgery, the IRO consortium provides the most compelling data. In 190 patients, SABR delivered durable control with single fraction dosing, showing striking improvements in local failure and progression-free survival. There were no grade 3 toxicity, no treatment-related deaths. SABR stands as a precise, non-invasive, and durable option, widening the curative possibilities in RCC. If you look at the metastatic renal cancer, which remains a formidable challenge, about 1/3 patients present with metastasis at diagnosis, and nearly 30% of those treated for localized disease will later develop distant mets. Yet, the past 5 years have reshaped the field. The landmark Checkmate 214 trial established dual checkpoint blockade, nivolumab plus ipilimumab, as a frontline standard, with durable benefit and 5-year progression-free survival nearly 30%, once thought impossible in renal cancer. Other pivotal trials like Keynote 426, Checkmate 9ER, and CLEAR trial shows powerful response rate which goes up to 70% with immunotherapy and VEGF combination. Though their long-term durability trials dual immunotherapy, the trend is clear. The systemic therapy has extended survival, but challenges persist, especially in oligometastatic disease. Here, the integration of local therapies like SABR is becoming increasingly vital. So, if you look at the guidelines, in oligometastatic setting, local therapy has become central to conversation. Both AUA, EAU guidelines endorse metastatectomy or ablative approaches in carefully selected patients, recognizing outcome worsen as metastatic burden rises. Here, SABR has emerged as a powerful option. Phase 2 trials show excellent local control, positioning SBRT as non-invasive alternative to surgery. The RAPPORT trial is especially compelling. SBRT combined with short course immunotherapy achieved 92% local control with overall survival of 90% at 1 year and 74% at 2 years. These findings highlight synergy of precision radiation with systemic therapy, marking SBRT as a key tool in modern metastatic renal cancer. In oligometastatic disease, SABR delivers impressive results. 1 year progression-free survival around 64% and more than 80% of patients remaining off systemic therapy at 1 year. This offers meaningful disease control without chronic side effects, achieved with very low toxicity. Equally vital is SBRT's role in oligoprogression. By ablating resistant colons in a few progressing sites, SBRT can extend the benefit of ongoing systemic therapy, delaying the need to switch lines in both settings. SBRT buys time, maintains quality of life, and integrates seamlessly with systemic approaches. It is not just a local therapy, but a strategic tool reshaping the entire course of renal cancer. Looking at the future direction along with systemic therapy, IROC has established SABR efficacy in renal cancer. Ongoing research is evaluating combination strategies which include immunotherapy along with SABR, VEGF, targeted therapy with SABR. The goal is to synergistic responses to be observed and improve the outcomes. The next slide shows and summarizes the active clinical trials. This chart summarizes the active clinical trials, which include Samurai trial, a phase 2 trial, Cytoshrink, ECOG ECRIN 8211, SWOG S1931, which all looks at the patient population with renal cancer with combination treatments. Now, quickly look at the technical aspect of the SABR. This case highlights the real-world power of SABR. MRI reveal synchronous bilateral renal cell cancers, both kidneys simultaneously and treated. Traditionally, surgery would mean stage or bilateral nephrectomy with serious risk or lifelong dialysis. Thermal ablation too would have been constrained by tumor size and location. Instead, stereotactic radiotherapy was used to treat both primaries non-invasively while preserving kidney function. These images from TRG 15.03 Fast Track 2 trial show exactly why SABR is so powerful in kidney cancer. On the left, figure A displays an axial treatment plan, multiple radiation beams coverage on the tumor, creating a peak dose at the target while sparing the nearby tissues. On the right, figure B shows a 3D reconstruction with arrows marking the beam spot tightly sculpted around the kidney lesions. The effect is high-dose ablative bath that conforms to tumor shape while protecting the bowel, spinal cord, and other kidney. This is the essence of SABR, transforming radiation into surgical-like tool, delivering millimeter precision without a single incision. Precision in SABR is not only about hitting the tumor, it is equally about protecting the organs at risk. This table from FastTrack-2 trial shows the critical dose constraint that guide renal SABR for spinal canal, bowels, and contralateral kidney, liver, keeping as low as possible. What you're seeing is the elegance of stereotactic planning in renal SABR. In top panels, multiple beams from varied gantry and couch angles coverage on the tumor. The dose wash reveals warm reds and oranges wrapping the lesion, while cooler blues fall away to shield bowel, spinal cord, and surrounding organs. The bottom panels highlight the target definitions. Red marks the internal target volume, accounting for breathing motion. Cane defines the planning target volume, allowing for set margins. Around these, the isodose lines providing 42 grays hugging the PTV. The 30 grays expanding outwards illustrate sharp dose fall off. This is the choreography of SABR, sculpted ablative radiation that eradicates tumor while preserving the normal tissue. This dose volume histogram tells the story behind the color maps we just saw. You can see the ITV, which is the target volumes, receiving higher dose while sparing the organ at risk, which includes stomach, large bowel, small bowel, liver, and spinal cord, sparing extra doses, preserving their function. Due to the time constraint, I just want you to go through with recent trial presented in ASTRO 2025. Earlier studies like FastTrack-2 showed us SABR is feasible and safe. Napster is aiming to push the fields further, testing not just precision dose delivery but its synergy with systemic therapy and possibility of reshaping standards of care. In this trial, the two-center study for clear cell renal cancer enrolling patients with T1b to T3a tumors, nodal disease, or low volume mets, patients are randomized to SABR alone or SABR plus pembrolizumab before surgery, nephrectomy following 9 to 12 weeks later, letting us analyze treated tumors directly. The primary endpoints are tumor reactive T cells and pathological response, with secondary endpoints in safety, immune profiling, and PD-L1 and 2 expressions. Napster is not just testing treatment, it's mapping how SABR and immune therapy together reshape the immune landscape of renal cancer. On broader context, other neoadjuvant RCC studies with TKIs or IO monotherapy show variable shrinkage but are generally safe. Opportunity with SABR is to embed into multimodal neoadjuvant strategies, aiming for stronger immune activation and reduced relapse risk. Once dismissed as radio-resistant, renal cell cancer is now at the forefront of radiotherapy. SABR has proven safe, precise, and effective, expanding from palliation into curative and systemic therapy combinations. With trials like Napster leading the way, we are seeing how radiation can synergize with immunotherapy to prime stronger anti-tumor responses. The future of RCC care lies not in isolated modalities, but in integrated, tailored, immune-driven strategies that promise to reshape the standard of care. These are the references, and I thank everybody for listening to this presentation, and I apologize not to be there in person. Thank you very much.
Thank you very much, Dr. Khan. Moving on, we have Dr. Narjis Muzaffar, who brings a vast experience of medical oncology work. She's currently working at Institute of Urology and Transplantation in Karachi with a specialist interest in urological malignancies. She has also been associated with Shaukat Khanum in the past. Welcome, Narjis. Good to see you.
Thank you, Dr. Khuramir, and thank you, Dr. Maria, for the invitation. It's always great to be back at Shaukat Khanum and its meeting. So when Dr. Maria asked me to talk about management of prostate cancer in countries with resource constraints, I found the topic to be a little difficult and not depressing, but because we do this in clinic every day. I mean, we work in Pakistan, we work with poor people all the time. I work at SIUT, where most of our patients are poor to middle class, and you are always tailoring treatment because, of the cost of drugs. So the treatment at SIUT is free, but we don't offer everything, especially the very expensive immunotherapy. So you're always modifying, tailoring treatment according to the patient's needs and the circumstances of the hospital, as well as their own social circumstances. You tell them, I'll see you in 6 weeks or 3 weeks after your staging workup is complete, and they'll say, well, I've come from 800 miles away, I can't come for another 3 months. So that's the reality of treating patients in Pakistan. But you do that every day. So while looking, obviously we don't have our own guidelines. We have institutional guidelines. We don't have national guidelines when it comes to treating prostate in our circumstances. So most of us follow the medical oncologists in Pakistan, and I know at Shaukat Khanum as well in Karachi, follow NCCN guidelines because they're very extensive, they're very good for the medical oncologists, and especially those of us who trained in the US, we are kind of maybe biased and we follow those guidelines. But I started looking at other guidelines, and I looked at NICE and EUA guidelines if there was anything, and I could be wrong, but the literature search that I did, I didn't find anything when it comes to their recommendations for countries like ours. I did find something from ASMO, Clinical Practice Guidelines, and ASMO suggests for countries with limited resources, you prioritize feasible treatments, focus on treatments that are available and affordable, adapt your guidelines according to your local needs. You also consult local experts, your colleagues, your other experts in your setting. Focus on evidence-based medicine, which is emphasize treatments with proven efficacy that can be delivered reliably in the local setting, so that you don't have to struggle every day with the patient. And you, of course, take into account patient needs. And what ASMO did in 2020, when ASMO updated their prostate cancer guidelines, they, together with the Singapore Cancer Society or Prostate Society, involved other countries like India, China, Malaysia, Korea, and Taiwan, and came up with these guidelines. So I think the first slide was, so these are the recommendations that they came up with, the Singapore Society and the ESMO Society. I looked at other literature, and I found something coming from Africa, especially from the sub-Saharan countries, the literature published in the National Library of Medicine, Annals of Global Health, and basically they were trying to look at the same thing. What can they develop in terms of their own, looking at their own population and resources, and develop guidelines so they can manage their patients better. And again, this is from Africa, sub-Saharan Africa. This is a press release, and so again, they have the same problems as countries like Pakistan, with very limited resources. I found a great, and I looked at it earlier also, but the Lancet Commission on Prostate Cancer, Planning for the Surge in Cases, and I'm sorry this is a blurred paper, the front page, but this commission, which was headed by Dr. I'm forgetting his name, is Dr. James from the Royal Marsden. They started the work in 2020. They took 4 years to develop guidelines, and they involved, the commission had like 40 people working on the commission, and these people were from all over the country. and globally they involve countries, people from Asia, from Europe, from North Africa, from America, and so the Commission projects a significant increase in prostate cancer cases and deaths globally by 2040, with annual cases rising from 1.4 million to 2.9 million and deaths increasing by 85%. And this really looks bad. This will disproportionately affect low income countries due to demographic shifts, where men are often diagnosed at advanced stages. And the report also highlights ethnic disparities, noting that men of West African descent have a higher risk, yet research is primarily focused on men of European heritage. And diagnostic methods in high-income countries can lead to both over and under testing, while in low-income countries, most diagnoses are made at later stage. The projected rise in cases is attributed to unavoidable demographic changes rather than lifestyle factors. So really, it's not like, people quit, the population stops smoking and the risk of lung cancer goes down. It doesn't work that way in prostate cancer. Many countries like ours and some African countries have a very young population, and in the next 20 years, they will be in their 40s and 50s, and some of them, because of the genetics, already are at high risk for developing prostate cancer. So this is like alarming, and I don't think the countries like ours or other African countries are ready for this surge. If you look at, this is the Lancet Commission, this is estimated new cases, and this is the deaths from prostate cancer. And the blue one is up to 2020, and the whole is 2020 to 2040. And if you look at the numbers, this is East Asia, South America, and this is Africa. The numbers keep increasing in these countries, and the incidence keeps going down in more developed countries, as well as the risk of death from prostate cancer. Again, this is very alarming, and for people who will be working with prostate cancer 20 years from now, will run into major problems in these countries unless we do something about it now. So other recommendations by the Lancet Commission was it emphasizes the need for significant interventions, particularly in poorer countries, to enable earlier diagnosis, and they also recommend that we need to implement awareness and education programs, build diagnostic and treatment capacities, boost earlier detection of metastatic disease, and trials in countries with lower resources. Now, this was the Lancet Commission, and I think this was very important. They did a lot of hard work. They took 4 years to develop these recommendations, and I think work is still going on. They work with other cancers also, but I think what they did was with prostate cancer was really wonderful. Now, coming to NCCN guidelines, I know some people don't like the NCCN guidelines, but the medical oncologists in Pakistan, I think all of us follow these guidelines. It just makes a life very easy. And these guidelines have been developed by not just by one institution in the US. They work with a good number of institutions, very smart people, very informed and educated clinical oncologists, medical oncologists, radiation oncologists, surgeons together. They involve people other than medical oncologists to come up with these guidelines, and they also involve other international centers as well. So when we look at NCCN, when we go in, what we generally do is we do this treatment by cancer type, and then we look at the most recent guidelines, updates for, for the global world, or, for every country. But if you want to look at the data or the recommendations for countries with limited resources, here's where you go. We hardly, I have to admit, I don't look at this very often. We all get excited about when we attend the ASCO meeting, and we get news of practice-changing results of some trials, and we get excited and we want to follow that, because you want to be with the rest of the world. You attend these meetings and you hope that you can do the same here, but unfortunately you can't always. So it's good for trainees who are now doing the fellowships. You should look at this. This helps in your clinical practice. It makes life easy. So this is the NCCN framework and I'll read it out to you. Applying available and affordable services in a logical sequence. Each NCCN framework builds on the one before it with incremental changes to the allocation of resources. This is what we are interested in, providing a structure for improving cancer care. So they divide this into 3 groups: the basic resources, the core resources, and the enhanced resources. Basic resources is treatment that improves disease-free outcomes, disease-specific outcomes. You use very basic stuff, nothing fancy. It doesn't improve survival. They're not talking about improvement in survival, overall survival, just disease-specific outcomes. The next step is core resources, and I think this is where we are in Pakistan. Core resources include services provided in the basic resources framework, plus additional services that provide major improvements in disease outcomes, example survival, that are not cost prohibitive. So, we do bone scans, we do PSMA scans, we do biopsies at SIUT, we do it for free for patients, and we offer first-line anti-androgens, and we offer chemotherapy, docetaxel chemotherapy. So these are not, this is not cost prohibitive if you have your own, if you have a center which is doing all this. And then, of course, the enhanced resources. Enhanced resources include services provided in the core services framework, plus additional services that provide lesser improvements in disease outcomes. You're spending more money, you're giving more time, but doing more studies. It may provide lesser improvement in disease outcomes, and are services that provide major improvements in disease outcomes, but that are not cost prohibitive. So immunotherapy, triplet drugs therapy, which we just heard about, these may not be very feasible to do in centers like Shaukat Khanum or at SIUT. So all societies tell us to adapt according to your local needs. So guideline adaptation, screening and early diagnosis, primary challenge and low resource countries, adapting guidelines for screening must be balanced. Now they're talking about screening and early diagnosis. So what NCCN suggests is that mass screening may not be feasible in countries like ours. It's not cost effective. You should focus on individuals at a higher risk of developing prostate cancer. Digital rectal exam doesn't cost much, and just increasing awareness, do public health awareness programs. We have social media. You can do a lot with public awareness programs. Now, I'm an examiner, so I know that all the fellows are, just learn this by heart. How do you risk stratify for prostate cancer? And if you look at this is what does the basic resource part tells you? Well, except for clinical C, T2B, T2C, 3A, 3, 4, this is all gray. This is like they don't want you to do. You can get away without doing any of this. If you are working in an institution where the patients are really poor and you have nothing, I'm not talking about Shaukat Khanum or SIUT, but there are places where it's very difficult for patients to get a bone scan or even get a biopsy. So you could just go by this. The next one is core. Core, they add more things like biopsies, but again, you don't have to do bone scans. I mean, you don't have to follow all this, but this is something to think about. I think it's good philosophy. And then the enhanced resources, you do almost everything. If the patient has the money, or if the institution is rich or the country is rich and can afford it. Now, I'm a medical oncologist, so patients generally come to me when they are usually when they are castrate resistant, they come to us from the urologist, or even when they are castration sensitive still, and they come to us for medical treatment. And in the basic resource part, NCCN, what is NCCN telling you? If this is more non-metastatic disease, you just follow them, just surveillance, that's it, do nothing. If it's M1 disease or they're symptomatic, you add your ADTs. Affordable, every institution almost offers it for free. And even if patients have to buy, it's not that expensive. So, but in the next group, the core resources, which improves the survival, remember, if it's M0 disease, you give ADT. But if it's M1 disease, metastatic disease, you do other things also. In castration sensitive, again, you add more for enhanced resources. In basic resources for CRPC, nothing. For core, add a few things. So the list goes on. You can look it up. Thank you. I think my time is up. So thank you for your attention. And if you have any questions, I'll be here. Thank you.
Thank you, Dr. Narjis, for such a wonderful talk and showing us a different perspective how we can treat our patients in resource-limited setting. And probably this validates many things that we are already doing. Okay, so the next speaker is Dr. Syed Mohammad Nazim from Aga Khan Hospital. He is section head and associate professor of urology at the Aga Khan University, Karachi, a fellow of the Royal College of Surgeons, Glasgow, CPSP, and the American College of Surgeons. He has over 50 peer-reviewed publications and several book chapters. His key interests include uro-oncology, laparoscopic urology, urolithiasis, and medical education. Please welcome Dr. Nazim.
I am very thankful to the organizers of 24th Shaukat Khanum Cancer Symposium for giving me the opportunity to present on the topic Seeing Beyond the Surface, Optical Advances in Bladder Tumor Detection. I am Dr. Syed Mohammad Nazim, working as the section head of urology at the Aga Khan University Hospital, Karachi, Pakistan. The proper diagnosis and efficient treatment for the bladder cancer is still considered a challenge in urology. Non-muscle invasive bladder cancer is characterized by high recurrence rate and progression. TURBT, which is the gold standard for the detection and treatment of bladder tumor, is because it not only provides the accurate histopathological evaluation, but it also impacts the risk of recurrence and subsequent patient outcome. The cornerstone for performing TURBT is white light cystoscopy, which not only gives us the diagnosis, that is local staging, but it is also used in the follow-up and surveillance of the bladder cancer. If we talk about the EORTC risk calculator, so out of the 6 parameters, 3 of them, that is number of the lesions, size of the tumor, and carcinoma in situ, requires proper cystoscopic evaluation, and hence the visual detection is central to the optimal diagnosis and treatment. 70% of the bladder cancer comprises of the non-muscle invasive bladder cancer, and especially the high-risk, high-grade non-invasive tumors pose a significant risk of the residual disease. The residual tumor can be present in up to 50% of the bladder cancers, and out of which 15% can be upstage. Especially the carcinoma in situ has a high recurrence rate of up to 50% at the first cystoscopy performed 3 months after TURBT. The healthcare costs for bladder cancer are among the highest of all malignancies because of the high recurrence rate, the associated need for lifelong surveillance, and repeated resections. Hence, the timely detection, appropriate risk stratification, and individualized treatment remains of paramount importance in the care of patients with non-muscle invasive bladder cancer. Now, what are the limitations of this conventional white light cystoscopy? Although it is sufficient for the identification of papillary lesions with the sensitivity of 85 to 90%, but for the non-papillary and flat lesions, it has lesser sensitivity, and it is unreliable for determination of low and high-grade cancers. It cannot assess the level of invasion, it can miss the smaller or satellite tumors, and the tumors located at the indistinct borders or at the margins. There is increased risk of cancer persistence, recurrence, and progression with the white light cystoscopy, especially for the high-grade bladder cancer. The enhanced endoscopic imaging technologies or optical enhancement techniques have given a new horizon in the management of non-muscle invasive bladder cancers. These include macroscopic imaging techniques, microscopic imaging techniques, and molecular imaging techniques. The macroscopic imaging techniques, they survey a large area of the mucosa. They include photodynamic diagnosis and narrowband imaging, and they provide additional contrast enhancement to distinguish suspicious lesions from the non-cancerous mucosa. These two modalities have been supported by several prospective trials and meta-analysis and are included in the EAU and AUA guidelines for non-muscle invasive bladder cancer. The other microscopic imaging techniques include autofluorescence and image 1S. Microscopic imaging techniques, they provide high resolution subsurface tissue characterization similar to what is found in histopathology, and hence they are said to give optical biopsy of the bladder cancer. These include confocal laser endomicroscopy or CLE and optical coherence tomography. The third is the molecular technologies, and we will be briefly touching upon this later on. The first is blue light cystoscopy or photodynamic diagnosis or fluorescence cystoscopy. So this is the technique in which two agents are used, 5-aminolevulinic acid or hexaaminolevulinic acid, which are instilled intravesically or intravenously. And once this porphyrin goes in the bladder, there is accumulation of protoporphyrin 9 in the cells, particularly the cancer cells, which show a stronger absorption and extended excretion as compared to the normal bladder tissue. Whenever a blue light source using the specialized lens and camera is projected to the bladder and it gets exposed to the protoporphyrin 9, it gives off a red fluorescence, while the intact tissue appears blue. Hexaaminolevulinic acid is preferred to 5-aminolevulinic acid because of its greater bioavailability, greater selectivity for the tumor tissues, brighter fluorescence, and shorter duration in the urinary bladder. So here you can see a cystoscopic image of the bladder with some erythematous mucosa without any obvious lesion. But when seen in the blue light cystoscopy, you can see a bright pinkish fluorescence area. These are the other images. On the left side are the white light cystoscopic images of the papillary tumor, and you can see on the right side in the image B some fluorescence on the mucosal surface. Image C is the cystoscopic image at the junction of the dome and lateral wall of the bladder, and there a lesion is difficult to characterize, while on the image D, which is the blue light cystoscopy, you can see a bright fluorescence in that image. Now coming to the outcome of blue light cystoscopy. So photodynamic diagnosis improves the sensitivity of diagnostic cystoscopy as reflected in the reduced bladder cancer recurrence rate. There is level 1 evidence which has shown that it leads to increased tumor detection and prolonged recurrence-free survival whenever utilized for the TUR. Photodynamic diagnosis produces higher scores than white light cystoscopy for both the sensitivity of the detected tumor and efficiency of TURBT as measured by frequency of relapse 9 months after surgery. And this blue light cystoscopy detects 40% more of the carcinoma in situ lesions as compared to white light cystoscopy. When we talk about the hexaaminolevulinic acid associated or assisted cystoscopy and progression, then in a systematic review and meta-analysis by Gekis et al., including 1,300 patients, it found that nearly 6.8% of patients who had hexaaminolevulinic acid assisted TURBT showed progression compared to 10.7% of patients who had white light TURBT. The blue light cystoscopy has certain limitations. It has high cost of examination and requires a longer duration for performance. It requires the use of specific endoscopic platforms. FDA has not approved blue light cystoscopy for the repeated use, and it is contraindicated within 90 days of intravesical immunotherapy. The false positive results can be seen for blue light cystoscopy, especially when there is history of recent TURBTs in case of intravesical immuno or chemotherapy for concomitant urinary tract infection, bladder inflammation, and scarring. Narrowband imaging. Narrowband imaging is another macroscopic high-resolution wide-field endoscopic technique. that improves the detection of bladder neoplasia through enhanced visualization of mucosal and submucosal vasculature. In contrast to blue light cystoscopy, there is no use of exogenous dye. However, there is need for a specialized narrowband imaging device which filters out the red spectrum from the white light with resultant blue and green spectra that are absorbed preferably by hemoglobin, and highlighting the contrast between the capillaries and the mucosa. Another advantage of narrowband imaging is that it can give the toggling functionality between or shift between the white light and narrowband imaging, and can give to the real-time evaluation of the suspected lesion. You can see in this diagram the principle of narrowband imaging. So it visualizes the tumor-associated aberrant mucosal and submucosal vasculature. The blue light gets reflected by superficial mucosal capillaries, and green light gets reflected by the deeper submucosal vessels. So on the left side, you can see the white light cystoscopic image with some erythematous areas in the bladder mucosa. And on the right side, you can see a bluish fluorescence of the tumor along with the prominent submucosal vessels which are seen in the blue and green on the narrowband imaging. This is another image. On the left side, you can see a papillary lesion in the bladder, and on the right side, the similar tumor as seen on the narrowband imaging. So when we talk about the results of narrowband imaging, a randomized controlled trial from Clinical Research Office of Endourological Society, which randomized more than 481 patients to white light TURBT and narrowband imaging assisted TURBT. And this randomized controlled trial showed that NBI reduced the 12-month risk of recurrence in low-risk patients from 27.3% to 5.6%. Another meta-analysis of 8 studies incorporating more than 1,000 patients showed that detection of bladder cancer was higher by narrowband imaging compared to white light cystoscopy on per person basis, per lesion basis, and for carcinoma in situ, narrowband imaging demonstrated 93% sensitivity, which is higher as compared to white light cystoscopy. Narrowband imaging also has certain limitations. It gives false positive results in up to 1/3 of the cases, especially post BCG, during the initial learning curve, and in inflammatory conditions. The quality of narrowband imaging cystoscopy can be impaired by the presence of blood in the bladder, which impairs the proper evaluation of the bladder mucosa. This is one of the recent studies, in fact, a network meta-analysis of randomized controlled trial published in BJUI, which showed the impact of enhanced optical techniques of time of transurethral resection of bladder tumor with or without single immediate intravesical chemotherapy. It included 22 studies involving more than 4,500 patients, and the interventions that I mentioned included TURBT with photodynamic diagnosis plus minus single installation, narrowband imaging plus minus single installation, and white light cystoscopy with single installation, and they compared it with the control group which was TURBT with white light cystoscopy alone. They compared the risk of recurrence at 12 months, and then they found that the blue light cystoscopy alone or blue light cystoscopy with single installation of chemotherapeutic agent showed significant response compared to white light cystoscopy, although the results for narrowband imaging were good, but they did not achieve the statistical significance. Autofluorescence. Autofluorescence is similar to the blue light cystoscopy because it relies on the fluorescence light tissue emission phenomena, with the difference that it does not require exogenous fluorescence dye and relies on the endogenous fluorophores that includes collagen, elastin, tryptophan, and NADH. This autofluorescence helps to differentiate malignant and healthy tissues, and there is no need for pre-installation of hexaminolevulinic acid. It uses the light within the ultraviolet spectrum. So here you can see the principle of the autofluorescence, and the tumor tissue, it generally exhibits the brownish hue, while the rest of the bladder mucosa shows the bright greenish fluorescence of the autofluorescence. Image 1S, which is also called as STARS Professional Image Enhancement System or SPICE. It's a multimodal imaging technology that incorporates 4 different digital imaging modes to modify the cystoscopic image. These include the Spectra A and Spectra B, which gives color tone shift algorithm to increase the contrast and better color contrast. chroma, which enhances and sharpens the image, and clara mode, which gives greater visibility in the darker regions. So image 1s obviates the need for preoperative installation of exogenous fluorescence material. So in the image on the left side, in image A, you can see a papillary lesion depicted on the white light cystoscopy, and you can see how much enhanced it is seen in the image B, which is actually the combined clara and chroma mode, while in the image C and image D, which include spectra A and spectra B mode, it further enhances the lesions. Multiparametric cystoscopy for detection of bladder cancer using the real-time multispectral imaging. It's a new modality which incorporates computer-assisted image processing technology, and it uses 6 different imaging modalities such as white light cystoscopy, blue light cystoscopy, narrowband imaging, autofluorescence, protoporphyrin 9, and multiparametric, that is digital fusion of all of the above. So in this picture, you can see various lesions, lesion 1, lesion 2, lesion 3, 4, and 5, as seen on the white light cystoscopy on the left side, and the various other modalities that are used in this multiparametric imaging, and the combination of all of them on the right side. And you can see the performance of multiparametric cystoscopic imaging on the right side for the papillary lesions as well as the flat lesions, and how good it shows these lesions. Now moving on to the microscopic enhancement techniques or optical biopsy technologies. These provide high spatial resolution and subsurface imaging, and they are complementary to wide field imaging modalities such as white light cystoscopy, blue light cystoscopy, and narrowband imaging, and they are not used in isolation. Confocal laser endomicroscopy is the first one. It produces real-time, high-resolution, microscopic, histology-like imaging. There is a requirement for intravesical or intravenous fluorescein, which acts as a contrast agent for the image acquisition, and a fiber optic probe, which is based on a 488 nanometer wavelength laser that is inserted through a working channel of the standard cystoscope and placed in direct contact with the mucosa and tissue. The video sequences are required which display dynamic imaging of the tissue microarchitecture, morphology, cellular architecture, and vascular flow. CLE is capable of differentiating high-grade and low-grade bladder cancers. A normal urothelium is characterized by larger umbrella cells which are located more superficially, organized small intermediate cells with the distinct cell borders. The low-grade papillary tumors are characterized by densely arranged but normal-shaped small cells which extends outward from the fibrovascular core, while the high-grade tumor and carcinoma in situ show markedly irregular architecture and cellular pleomorphism. So here in this atlas, you can see the images on the left side for the white light cystoscopy on the top, the CLE in middle, and the conventional HNE in the bottom. On the top left corner, you can see a normal bladder mucosa and the appearance on CLE, which is very much similar to what we see a normal urothelium on HNE staining. For the low-grade cancer, you can see the cystoscopic image of a papillary lesion, and you can also see the fibrovascular core and the arranged regular cells which are arranged in layers. For the high-grade and carcinoma in situ, the CLE shows the cells which have lack of the polarity, the pleomorphic cells, and difference in their size, and more aggressive looking as we see in cases of the HNE. CLE also has certain limitations. It does not improve the tumor visualization for the occult lesion. It cannot be served as a tool to survey the whole bladder and has a very small field of the view. The optical depth of CLE is limited to the lamina propria, therefore you cannot assess whether the lesion has gone deeper down into the muscular tissue. OCT or optical coherence tomography, it provides real-time, high-quality cross-sectional image of the superficial tissue, and it gives the mucosal and submucosal imaging in the z-axis up to a depth of 2.5 millimeter. It does not require any exogenous contrast agent, and OCT is actually the optical equivalent of ultrasound, but instead of using the sound waves, the reflective waves of near-infrared light is used. The key strength of OCT is that it can depict the depth of penetration and hence can detect and diagnose the stage of the tumor and possibility of tumor invasion deeper in the muscularis propria. So normal urothelium shows weakly scattered dark layer on the top of the right fill. Lamina propria is the brighter layer with highest scattering intensity, and muscularis propria is less scattering layer beneath the lamina propria. In the cancerous tissue, these anatomic layers of the urothelium are lost. OCT has shown a sensitivity of 98% and a specificity of 70% for the detection of pathologically confirmed tumors. However, it has the limitations of being false positive due to the disruption of bladder wall from erosions, scarring, or granuloma formation. It is also operator dependent and needs training. Now the last one is the molecular imaging, which combines the optical, macroscopic and microscopic imaging along with the intravesical administration of small molecules, peptides or antibodies. The ideal agents are those which should bind to the highly expressed, favorably specific targets of the bladder tumor, should have good safety profile, and should have a better pharmacokinetics, including the high stability in urine. Anti-CD47 is the agent which is most extensively studied, and it targets a surface marker CD47 which is expressed on more than 80% of the bladder tumor cell. These molecular imaging are nowadays used more and more, but still they are investigative. So now move on to the last slide, which is actually the summary of all these adjunct optical enhancement or imaging techniques for the bladder cancer. So PDD and narrowband imaging are the macroscopic techniques, CLE and OCT are the microscopic technique. Both photodynamic diagnosis and CLE relies on the principle of fluorescence. Narrowband imaging has the mechanism of absorption, and OCT has the mechanism of scattering. The contrast agent is required for PDD and CLE, but not for narrowband imaging and OCT. The resolution is in millimeters and centimeters for macroscopic techniques like PDD and MBI, and it's in the microns for CLE and OCT. The macroscopic techniques only assess the surface or mucosa, while the OCT has a depth of penetration of up to 2.5 millimeters. And the standard rigid scope are used for PDD and narrowband imaging, while the specialized probes are utilized for CLE and OCT. And all four are being used in the clinical setting, specifically the photodynamic diagnosis and narrowband imaging. With this last slide, I thank you all for your patience, and any questions are welcome. Thank you very much.
Thank you, Dr. Nazim, for such a wonderful talk. So now we will move on to the question and answer session. And can I request the IT team to please let us know if all the online speakers are there?
Thank you. I have a question for Dr. Narjis. This is Dr. Muni from SKM, I'm a radiation oncologist. So, a great talk highlighting the limitations in our setting regarding the prostate cancer. So, we know that these second generation anti-androgens like Enza, apalutamide, darolutamide have consistently shown the survival benefit in prostate cancer, but given their cost and availability in our country, so how do you prioritize our patient regarding this? And are there any access programs available or working going on to make them available for our population? Thank you.
Yeah, so let me get to the second one first, the access programs. We have now few pharmaceutical companies along with Baitul Mal, I'm sure it's in every city, at JPMC in Karachi are offering drugs. Some of these drugs is like enzalutamide. These are kind of access programs. They take time. Sometimes a patient may end up buying the first dose, but then, they get the drug for free. So this is for breast cancer, for other cancers also. So we are getting drugs. Now we have to be careful. Even the government has limited resources. We want to choose our patients and the treatment and the drugs wisely. You don't want to bankrupt your own institution or the Baitul Mal. So you have to look at, I showed the NCCN guidelines, in even the Lancet guidelines or the recommendations, you look at the patient and you look at, is this patient, elderly patient who is spending with a poor ECOG, do you want to invest so much in that patient compared to somebody who's younger with a better ECOG will be able to tolerate the treatment. Remember, it's not just financial toxicity, it's you're thinking of drug toxicity as well. So there are so many things that when I send a patient for enzalutamide to the Bethelmal, I make sure I send the right patient. That, you know, it's not, we will not refer everyone, because then nobody will get the drug, right? So you choose your patients wisely. And again, your first question at SIUT, you know, we offer for prostate cancer surgeries free radical prostatectomy. We offer bilateral orchectomy. We don't give LH-RH agonists for free at SIUT. We have so many surgeons, well-trained surgeons, and you know, if the patient is a candidate, we offer them bilateral subcapsular orchectomies. That's a standard. Patients get radiation for free. We have LINAC accelerators. They get external beam radiation. We also give brachytherapy. So there's a lot that you can do in your institution. You know, I've worked at Shaukat, Khanum, and I know you can do so much with limited resources. It's very unfortunate that we are not able to provide triplets or the best of treatment or for RCC, immunotherapy, and you know, so on. But this is what we do. Yeah.
I think from the perspective of Shaukat Khanum, Dr. Muneeb, I would like to add that from next year we will be getting 6 abiraterone per month, both for Peshawar and Lahore. But you know, if you look at that from that perspective, many of our patients will be getting these drugs. Yeah.
Yeah. So we offer docetaxel chemotherapy to our patients, and obviously they don't pay for it. We also are now giving abiraterone. What we are doing is we are following the Indian data, starting with 1 tablet a day, 250 milligram with you know, low-fat diet. Glass of lassi in the morning, buttermilk in English, with your abiraterone. So the institution is now giving it for free. Some patients buy their own drug. They still want to use the 4 tablets a day because, you know, they go to other institutions, get opinions from other medical oncologists. I don't have a quarrel with that, but at SIUT, we are offering it to patients who need it, 1 tablet a day. And chemotherapy, of course, we have been doing it for the past 20 years.
On the same note, sorry, can you hear me? On the same note, I've got a question for Professor Jones. You know, with a resource-limited country like ours, you've spoken extensively about the newer generations of drugs, which definitely are going to be more expensive, but you talked about estrogens as well. In your view, how do you feel developing estrogen therapy for resource-limited countries where we don't have funds to try out the newer medications for prostate cancer patients?
Yeah, so what I can't comment on is the exact costs of these treatments, but of course, you know, estrogen, we use in the trial, we've been using exactly the same patches that we use for hormone replacement therapy in menopausal women. You have to use 3 at a time, so it's a slightly higher dose. But my understanding is that these are certainly long off patent drugs, and my understanding is that they are relatively cheap. Now, I'm afraid I don't know how true that is in countries like your own, and I think, you know, I'm interested in the previous comment about orchidectomy, because orchidectomy is a highly cost-effective treatment, and I'm not sure that transcutaneous estrogen really offers any great advantage over orchidectomy, apart from its reversibility, which is not something that, generally speaking, we as doctors desire, but for some patients that's important. So the way I see, I think the estrogen, you know, we're still to see the results of the non-inferiority trial in the metastatic patients. If you remember, I showed you the non-metastatic group. We're going to see those very soon, I understand. And I think even in countries like my own, I don't foresee that transcutaneous estrogen is going to be widely adopted, but I already use it for some patients where I feel there's a particular reason why they would not tolerate LHRH agonists. For example, I've got a patient who had an LHRH agonist as part of his radiotherapy treatment a few years ago, had a terrible time with hot flushes, came back with metastatic disease, and so we've now gone ahead and used transcutaneous estrogen. So I suspect it will only ever have a selected role in high-income countries like my own, but I think it will be really interesting to look at the economics of it in a country like your own.
Can I ask Dr. Jones? Dr. Jones, where is docetaxel now in your clinical practice? Are you using it anywhere?
Yes. So we discussed some of the triplet data for docetaxel, which of course are they're indirect data because we don't have a trial of doublet RP with or without docetaxel. We've only got the wrong trials, if you like. But the network meta-analyses do suggest there are some patients who get greater benefit from triplet therapy for HSPC rather than doublet RP therapy. So particularly in fit, docetaxel fit, high volume patients, high volume synchronous disease patients, I am offering those patients triplet docetaxel for HSPC. And, of course, it's still really their first line treatment. Once a patient has failed doublet RP therapy for HSPC, actually really my first line treatment for RP resistant cancer now is still docetaxel chemotherapy. So I probably use more docetaxel now maybe than I ever did because actually patients are generally speaking are fit and well when they progress on their doublet RP therapy and are suitable for docetaxel.
Okay, thank you.
So Maria Khan, are you there? Would you like to any comment or any?
I have a question for Dr. Khan, Dr. Habib. Is he there? Yeah. Okay.
Yes. Yes.
For SABRT, is that good for non-clear RCC? Is that, I don't know the clinic, I don't know the data, so.
Mainly it's for the RCC, if you like a clear cell and chromophobe and other pathology.
Okay.
What transition cell, PCC, that's what you mean. If
non-clear cell RCC, like you just said. Okay, so chromophobe tumors.
And others are included, but not widespread, because these we are talking about early phase trial. Phase 1, phase 2, and 2 center trials. So it is not like a randomized controlled trial for widespread and number of patients are limited. So we're still yet quite a league to go to come up with a randomized trial and coming up with the consent. But nonetheless, the renal cancer is a very challenging cancer to manage, especially with people who are not fit. So it's still the standard is, I have to stress, that the surgery is the standard for early cancer we're talking about. That would, these are the group who never going to get the radical treatment because of their comorbidities or their other problems they cannot fit. So these group, if you try to treat more radically with SBRT, SRS, or CyberKnife, the outcomes are good. You can see the control rates going up to 90 to 80, 90% and more kind of thing. And that's not heard of because they die because of the metastatic disease. And then the other area is when you have oligometastatic disease. You try to target it. Just remember the era of lung cancer when we started, like about having early tumors which cannot be curatively surgically resected. And now it is a common practice to use those things. So we are moving into those phases in those era for renal cancer, which was very difficult to treat a couple of decades ago. So we have to look in the context. Yes, we can treat it. The way it works is quite different from the external beam radiotherapy. The evidence for small number of cases when we have already a very small data is going to be difficult to justify, but we can consider. If you see clinically, if there's no other options, yes, why not?
Okay, thank you.
Thank you, Dr. Habib. Rob, so I have got another question for you. In your clinical practice, how is your experience with the safety profile of all these newer agents like PARP inhibitors? And after that, the next question will be that how is your experience with the safety profile of lutetium therapy? Because these are therapies which we are giving to those patients who have had multiple lines of therapies and they have increasing age and have certain comorbidities as well. So what is your experience regarding that?
I think that's a really important question. Let's talk about I'll deal with the lutetium one first, because actually I have no routine access to lutetium. I've really only used lutetium in trials. We've had a very limited access outside trials. And I think, generally speaking, lutetium is quite well tolerated, but it does cause, because PSMA is expressed in the salivary glands. And although it's kind of rather dismissed in the trial data as a non-serious toxicity, the dry mouth and the dysgeusia for some patients can be really unpleasant and really long, quite long duration as well. I mean, since I prepared the talk, of course, we have actually seen the results of the PS Medition trial at the ESMO meeting last week, and it's quite interesting that actually there is a suggestion that there's quite, this may be quite a long-term problem for patients getting PSMA lutetium in the hormone-sensitive prostate cancer setting. So generally speaking, it's well tolerated. We're not seeing a lot of problems with the bone marrow suppression, for example. And I would say that whilst it's different from chemotherapy, obviously, it probably is more acceptable on average than, say, docetaxel would be in a patient. The PARP inhibitors, I mean, I've got some real concerns about PARP inhibitors coming through in the a widespread use in the non-BRCA population, because whilst it may work, it definitely doesn't work as well as it does in a BRCA patient. And of course, these patients have a better prognosis than the BRCA patients, so they're actually going to be on the treatment for longer. And if we then translate that through into the hormone-sensitive population, where, of course, the real success of the ARPI drugs is that it not just keeps people alive longer, but it enables them to carry on with a near normal quality of life for much longer. I really worry that if we start loading drugs like PARP inhibitors, which are not too bad in terms of toxicity, but they definitely add quite a lot on top of just endocrine therapies. So, I mean, the main problem with the PARP inhibitors is anemia, but patients often just don't feel, they're just reduced energy levels, low-grade GI toxicities, and then latent anemias and the need for dose modification. Now, the anemia can nearly always be managed with dose modification, but I do think that, generally speaking, the quality of life on a PARP inhibitor, or on a triplet therapy of ARPI plus a PARP inhibitor, is a step down from just the doublet ARPI therapy. And so we really do need to select patients and counsel our patients well in the choice of adding in PARP inhibitors. So yeah, I think there's an awful lot still to explore beyond what will be the headline results of these trials.
Thank you, Rob. So I wanted to close the session, but before
Is Dr. Nizam with us from Arhan?
Each year we have got a new molecule for the RCC. What's in your choice of treatment? Sunitinib, sorafenib, pembrolizumab, or combination? One thing. Second is the duration of treatment. Because these patients, they live long, some of them with the metastasis for 2, 3, 4 years. So what should be the duration of treatment in prophylactic advanced cases and in the metastatic, please?
Just coming back to the renal one, I think the standard approach at the moment is the combination treatment, which gives the best outcome. So if you want to individualize, you have to make sure that you're individualizing the treatment. Sometimes, like, maybe it's not operable at present, but if you get a very good response rate, it may become operable, or you can do certain treatment like SABR. So I have 1 or 2 patients who was not operable at that time, but when we started a treatment like lenvatinib with the pembro, we had a very good response, everything shrink down, and we were able to get surgery done effectively although he had a very complete pathological response, even on the surgery, there was no, and the mats that we took out does not show any residual cancer either. So you have to, so just give you an example. Similarly, if you have a long survival, you want to achieve a young patient, and where you may not be able to surgically resect it, you would be going for like doublet IO combination kind of thing, ipi-nivolumab. That's what my approach is. And now coming back to your, there are quite a few questions there. So other things that you asked for, what duration you would go, and
Yes, please.
if the matter are how long you're going to continue, is always challenging. There is some consideration, like if you have a very stable disease, if you see those tails with immunotherapy, with the people that are surviving longer without any progressive disease or any other disease appearing. So we have to look at the concept. So you got a patient, I'm just going to create a scenario. So you got a patient who you treated initially, had a very good response, and now got only 2 or 3 areas which are visible. I'm not going to about functional imaging, just any imaging that you use. And you think that things are not progressing and things are stable. Number one, I would try to go more radically for the oligometastatic disease area, control it, and after 2 years, I might stop the immunotherapy at least to give them a relief from financial or any other burden point of view. So that's roughly the mark that I get very comfortable. Even for a year, people will be comfortable about it, but there's a little bit of a difference of opinion how you're going to approach it. But coming up to it about a year at least with a stable disease, more radically treatment. But if you have other group that you have widespread disease, then I think the jury's out. So people would try to carry on if they can, and if you have ongoing response going on, then you might try to carry on with those ones. I think I would ask Professor Jones about his opinion about in this scenario as well, if he wants to put some additional information into it.
So I won't add. Actually, I stopped treating renal cancer a couple of years ago. So I'm less up to date than you on that one.
No, thank you. So roughly about, at least I would start, get the maximal response. And if it's stabilized for at least 6 months or a year, then I can consider about those things. But again, the recommendations are recommendations. You have to look into the context of those things.
Okay, thank you.
For enlightening us with their experience. So there was a lot to learn for us, and I hope that we meet again next year in the same session and have further updates as the things go on. Thank you, and have a good day, and enjoy the rest of the sessions.